You took your pill this morning. You did exactly what your doctor told you to do. You have been doing it faithfully for years. Same medication, same dose, same routine. And yet something is wrong. Your waistline is expanding even though your diet has not changed. Your energy is gone before noon. Your blood sugar numbers are creeping in the wrong direction, and nobody can explain why. Here is what nobody told you. For millions of adults over 60, the medication prescribed to protect your heart may be doing something else quietly, steadily, and invisibly. It may be rewiring your metabolism, storing fat around your organs, and pushing your body toward a diabetes diagnosis you were never supposed to get. A study published in the Journal of the American College of Cardiology found that patients on a common class of blood pressure medication had a 22% higher risk of developing type 2 diabetes compared to patients on alternative treatments. 22%. That is not a rounding error. That is nearly 1 in 4 people. In the next few minutes, I am going to show you exactly which medication is doing this, how it is happening inside your body right now, and what you and your doctor can do differently, starting at your very next appointment. Here is what most people do not realize. The problem is not that the medication stops working for your blood pressure numbers. In many cases, the numbers on the cuff actually look fine, normal even, and that is exactly what makes this so dangerous. You feel reassured by a reading that is hiding the damage happening underneath. While your blood pressure appears controlled, these medications are increasing insulin resistance in your cells, raising your triglycerides, suppressing the good cholesterol your body needs, and locking your metabolism into a state that makes weight loss nearly impossible. Your pancreas is working harder, your liver is storing more fat. And most physicians are not connecting these dots because they are looking at your blood pressure number and calling it a success. Mainstream medicine has been slow to update its prescribing habits even as the research has moved on. And the people paying the price for that gap are adults over 60 who deserve better. My name is Dr. Richard Wells, and I have spent over 2 decades working with adults over 55, people managing blood pressure, blood sugar, and the complicated overlap between the two. I have reviewed the research on this issue carefully, and I have sat across from far too many patients who looked at me and asked the same question. Why did no one warn me sooner? I am done staying quiet about this. You deserve to walk into your doctor's office with the right questions, the right knowledge, and the confidence to have a real conversation about whether your current treatment plan still reflects the best available science, or whether it reflects a habit that formed decades ago and has simply never been revisited. Everything I share with you today is grounded in real medical research, explained in a way you can actually use. Today, you will learn exactly how this medication class disrupts your metabolism and drives weight gain, the specific biological process that raises your diabetes risk, and why your blood pressure number hides it, and the precise questions to bring to your doctor that could change your treatment plan entirely. Stay with me through all of this. The third point is the one that most people never hear, and it may be the most important conversation you have with your physician all year. The first mechanism is called beta-adrenergic blockade, and it sounds complicated until you understand what it actually means for your body every single day. Many people do not see their blood pressure medication as something that touches their metabolism. They think it simply slows the heart down, lowers the pressure, and everything else stays the same. That is not what is happening. When a beta blocker occupies the receptors in your heart and your cells, it does not just slow your heart rate. It also blocks the hormonal signals that tell your body to burn stored fat for energy. Adrenaline and similar hormones are your body's natural fat-burning trigger. Beta blockers sit in the lock, so those signals cannot get through. The result is that your body shifts from burning fat to storing it, quietly, consistently, with every passing day. Think of it like a furnace with a sealed flue. The fuel is there. The fire is lit, but the energy has nowhere to go. It builds up, it accumulates. And over months and years, that accumulation shows up as visceral fat around your abdomen, the most metabolically dangerous fat your body can carry. A comprehensive meta-analysis in the British Medical Journal confirmed that patients on beta blockers gained an average of 1.2 kilograms more than patients on alternative antihypertensives during the same treatment period. That may not sound dramatic, but combined with the metabolic slowdown happening at the cellular level, it creates a compounding effect that your scale does not capture and your annual checkup does not reveal. I once treated a 67-year-old woman named Margaret who came in convinced she had a thyroid problem. She had gained 11 pounds over 2 years without changing a single thing about her diet. She was walking 3 times a week. She was eating well. Her thyroid panel came back completely normal. What had changed 2 years earlier was her blood pressure prescription. Once we identified the connection and worked with her cardiologist to transition her to a different medication class over 8 weeks, the weight stabilized within 3 months. She did not lose the 11 pounds overnight. But she stopped gaining, her energy returned, and for the first time in years, she felt like her body was working with her instead of against her. Stop right now and honestly think. Has your weight increased in the last 2 or 3 years without a clear explanation? Has your energy dropped? Comment the number of years you have been on your current blood pressure medication. I want to understand how many of you this is affecting. The fix for this specific mechanism is not complicated. You do not change your diet more aggressively. You do not exercise harder against a medication that is limiting your capacity to do so. The fix begins with a conversation. Ask your doctor whether your blood pressure medication falls into the beta blocker class, specifically whether you are taking metoprolol, atenolol, bisoprolol, propranolol, or carvedilol. If the answer is yes and your only diagnosis is hypertension without a heart condition, that is the opening question for a much larger discussion about your options. Now, the second mechanism is even more alarming because it happens invisibly below the surface of any standard blood test your doctor is likely to run. And when I explain what it does to your pancreas, you will understand why the diabetes risk is not a side effect. It is a predictable consequence. The second mechanism is insulin resistance, and beta blockers drive it through 2 separate pathways simultaneously. Most people believe insulin resistance is caused by sugar intake or inactivity. And while those things matter, what most people do not know is that certain medications can force your cells into a state of insulin resistance regardless of how well you eat. Beta blockers suppress a process called glycogenolysis, the release of stored sugar from your liver into the bloodstream. That sounds like it should help control blood sugar. In the short term, it can actually mask dangerous low blood sugar episodes in diabetic patients, which is one of the reasons these medications require careful monitoring. But the longer-term effect is different. By disrupting the normal signaling between your liver, your pancreas, and your cells, beta blockers progressively reduce your cell's sensitivity to insulin. Your pancreas has to produce more and more insulin to achieve the same result. Over time, that system breaks down. Picture your cells as a room with a locked door. Insulin is the key. In a healthy system, one key opens the door easily. Insulin resistance means the lock is getting stiffer. Your pancreas has to produce more keys, use more force, work harder just to open the same door. Eventually, even with maximal effort, the door does not fully open. That is type 2 diabetes, not a failure of willpower, but a failure of a system that has been under chronic mechanical stress. The Journal of the American College of Cardiology meta-analysis I mentioned earlier was not a small study. It pooled data from multiple large trials and found that beta blocker users had a 22% higher incidence of new-onset type 2 diabetes. For adults over 60 who are already in a pre-diabetic range, and nearly half of American adults over 65 meet that criterion, this is not an abstract risk. It is a meaningful push in the wrong direction from a medication that was supposed to be helping. A 72-year-old patient I'll call Robert came in for a routine blood sugar check. His fasting glucose had climbed from 98 to 118 over 18 months, solidly into pre-diabetic territory. He had not changed his diet. He exercised regularly. His family had no history of diabetes. He had been on atenolol for 4 years. When we reviewed the timeline alongside his lab trends, the correlation was clear. We worked with his physician to transition him gradually to an ACE inhibitor, a medication class that actually offers protective effects for kidney function and blood sugar regulation. Within 6 months, his fasting glucose had returned to 101. Not perfect, but the trajectory had reversed. Ask yourself honestly, when was the last time your doctor checked your fasting insulin level? Not just your blood sugar, but your actual insulin? Most standard panels do not include it. Comment below if your doctor has ever ordered a fasting insulin test for you. Your answer will tell me a great deal about whether this gap in monitoring is as common as I believe it is. The solution here is twofold. First, ask your doctor to add fasting insulin and triglycerides to your next blood panel if they are not already included. Elevated fasting insulin is the earliest warning sign that insulin resistance is developing. It shows up years before blood sugar numbers move. Second, ask specifically whether your blood pressure medication class is contributing to this pattern and whether a calcium channel blocker or an ACE inhibitor or an ARB would be appropriate alternatives for your situation. And now we arrive at the third point, the one that should change the actual conversation at your next appointment, because this is not just about what your medication is doing to you. It is about what a better medication could be doing for you instead. The third and most important point is this. The medical community already knows the alternatives are better for most seniors with uncomplicated hypertension. This is not an emerging theory. The landmark ASCOT Trial, the Anglo-Scandinavian Cardiac Outcomes Trial, published in The Lancet, followed over 19,000 patients and compared beta blockers against a calcium channel blocker combined with an ACE inhibitor. The trial was stopped early because the results were so clear. The group on beta blockers experienced significantly more strokes, more heart attacks, and more new diagnoses of diabetes. The alternative group had 23% fewer major cardiovascular events. Following that study and multiple confirming trials, the United Kingdom's National Institute for Health and Care Excellence formally removed beta blockers from their recommended first-line treatment for hypertension. They are no longer the preferred choice in British guidelines. Many American guidelines have followed. And yet, millions of patients in the United States are still taking these medications as their primary blood pressure treatment, often because the prescription was written years ago and no one has revisited it since. The two medication classes that the evidence now strongly supports for seniors with uncomplicated high blood pressure are calcium channel blockers, with amlodipine being the most commonly prescribed, and the ACE inhibitor or ARB family. Medications like lisinopril, ramipril, losartan, and olmesartan. Calcium channel blockers do not carry the same metabolic risks. They do not suppress your fat-burning signals. They do not push your pancreas toward insulin resistance. ACE inhibitors and ARBs actually carry protective effects for kidney function and have shown lower fall risk profiles, which matters enormously for adults over 60. A 74-year-old patient named Dorothy had been on a beta blocker for 6 years when her cardiologist revisited her prescription and transitioned her gradually over 8 weeks to amlodipine combined with losartan. Within 3 months, her fasting blood sugar had normalized. She lost 7 pounds without any intentional dietary changes. She described feeling like herself again for the first time in years. Her blood pressure readings were actually more consistent, not less, on the new regimen. Here is exactly what you should do before your next appointment. Write down these 3 questions and bring them with you. Ask your doctor, was my beta blocker prescribed specifically for hypertension, and does that still reflect current evidence-based guidelines? Ask, have we evaluated my fasting insulin and triglyceride levels recently, and what do those numbers show about my metabolic health? And ask, would I be a candidate for transitioning to a calcium channel blocker or an ARB based on my complete health picture? Those 3 questions give your physician everything they need to have a real, evidence-based conversation with you. And if any transition is recommended, confirm the tapering schedule. A responsible physician will reduce beta blockers gradually over 4 to 8 weeks and monitor you throughout. Never stop a beta blocker abruptly. That warning is not optional. Stopping suddenly can trigger a dangerous rebound in heart rate and blood pressure that in some cases leads to a heart attack or serious arrhythmia. Any change must be supervised and gradual. Let me bring this together for you. We covered 3 things today. First, how beta blockers block the hormonal signals that allow your body to burn stored fat, leading to unexplained weight gain that no amount of dieting will fully reverse while the medication is working against you. Second, how those same medications suppress the metabolic signaling between your liver, your pancreas, and your cells, increasing insulin resistance and pushing your body toward a diabetes diagnosis that the research says is a predictable consequence, not a coincidence. And third, what the evidence actually supports instead, and the specific questions that can transform your next appointment from a passive check-in into a genuinely productive medical conversation. If you have been on a beta blocker for years and you have been experiencing these symptoms, if this is the first time anyone has connected these dots for you, I want you to hear this clearly. It is not too late. The human body has a capacity for recovery that genuinely humbles me after all my years in medicine. Metabolic damage from medication can be reversed. Blood sugar trajectories can be corrected. Energy can return. It starts with information, and it continues with one honest conversation with your physician. Think about what it would feel like to wake up with real energy again, to walk up a flight of stairs and feel capable instead of winded, to look at your lab results and see numbers moving in the right direction, not because you punished yourself with a stricter diet, but because your medication is finally working with your body instead of against it. That is what this is really about. Not just a number on a blood pressure cuff, but your independence, your confidence, your quality of life in the years ahead. I want to hear from you. Has your doctor ever reviewed your blood pressure medication against current evidence-based guidelines, or are you still on the same prescription you received 5 or 10 years ago? Leave your answer in the comments. I read every single one, and I mean that. Subscribe to this channel. Every week I share evidence-based health information specifically for adults over 60. The kind of research your doctor may not have time to explain, translated into language you can actually use and act on. If this helped you, hit the like button right now so more people over 60 can find this video before it is too late for them to have this conversation. Write the words "reviewing mine" in the comments if you are planning to bring this to your doctor. Your commitment may be exactly what someone else needs to see to take that same step. And share this video with someone you care about, a spouse, a sibling, a parent, a close friend. You may never know whose life you change, but you will know that you tried. This is Dr. Richard Wells. Take care of your body. It is the only one you have, and it is worth fighting for.